have a semi-international speaker here. Michele Viana, we know each other for a couple of years. He's an Italian colleague doing lots of research in different parts of headache research. And he also kind of put one foot into Switzerland, and he does some research at the center in Bern. Please, Michele, you tell us about migraine aura, the differences between the clinical and definitions of this part of migraine.
Thank you to the organizers. Pleasure for me being here. Different topic, but I like it very much. I've been studying migraine auras for many years. I think it's a really fascinating and wonderful world. And let's start from to focus the problem. Migraine aura is a very common phenomena. About 30% of migraine patients experience migraine aura, which leads about to a prevalence per year to about 8% of the general population from a study of Rasmussen, but the prevalence in the general population is for sure much higher because there is a certain part of the population that has just migraine aura without any headache, and this part of the population was not included in the studies by Rasmussen. So this phenomenon is quite common in the population. And another thing is very important is the thing that the migraine aura present a wide spectrum of phenotype, and you that do the clinical practice daily, you know that, okay? A lot of different presentation, and the more you ask patients, the more you get different scenarios from them, okay? So, finally, the International Classification of Headache Disorders provides criteria, and here we get the most updated, and where we have the definition of migraine aura attack, which are fully reversible visual and or sensory and or speech disturbances that needs to have at least 3 of the 6 characteristics reported in the criterion C. The thing that I want you to notice, please, and we will deepen this aspect later on, is that if you take these single criteria, each one of those may be not always true, okay, in 100% of case. But at the end of the day, of course, the whole criteria has a very high specificity and sensibility. So the committee of the International Headache Society that provided this criteria did a very good job. But there is a problem. The problem is that these criteria maybe they can have some other uses, unplanned uses. For example, educational uses, some consultation. Many medical doctors in the world, even neurologists, okay, can learn what is migraine aura, can consult on internet what is migraine aura and its features via these criteria. This happens for many reasons, okay? Because, for example, these criteria are released by the world's leading headache scientific society. It is quick, easy to find the web. These people, for example, you think an epileptologist that want to check the features of migraine aura to compare with the epileptic seizure. Okay, you don't want to waste time with PubMed, with books. What do you want to do? Just check on the maximum headache society. So go to the web on the headache classification of the IHS. If you are, for example, a headache doctor and want to do the same for epileptic seizure, you go to the ILEA classification. So it is quite obvious. And so it checks the features of the migraine aura to learn about migraine aura. And also, another thing is important, is translated in several languages. These are the reason for which the classification it has some educational also uses. The problem is that this is a consequence that some few sub-criteria are extracted and isolated and used in some cases in the wrong way, in some setting. And this can be dangerous in some cases. So the ICHD criteria are very important, allowing us to make diagnosis of a given condition even when having such a wide spectrum of presentation. But we need to keep in mind that the single criteria or sub-criteria are not always true, so we need to know what is the real clinical spectrum of migraine hour, provided by the clinical study, and I will show you, okay? So in my talk, I will show you the classification criteria and what the clinical studies and the review told you. So starting from from the top, okay? So the classification indicate visual disturbances. Okay, which are they? In the criteria C, they say that this is just positive scintillation, but there's no example in the criteria. You need to search in comments. They say that there is a fortification spectrum, that is a zigzag line, a zigzag figure, with angulating scintillation edge that can be accompanied by the scotoma, or in other case, scotoma without positive phenomena may occur. Stop. No other description of visual disturbances in the classification. I was quite disappointed when I realized that, because you know, visual aura is much more than that, okay? So when I started performing studies in migraine aura, I gave my patient a diary to record migraine aura during their aura prospectively, and I received hundreds of scenarios, very different type of migraine auras. So at the beginning, I asked myself how to synthesize them, to describe. I started from the beginning, from a very simple way. I decided to use the elementary visual symptom for dissecting every aura from every single, basically, symptoms. For example, in this image, I wouldn't use one single word like a fortification spectrum, but two elementary visual symptoms like a zigzag lines and a flash of bright light. So after 216 auras, I had a table with the frequencies of all the elementary visual disturbances that are flashes of bright light, foggy blurred vision, zigzag lines, scotoma. We are going down from the top to the down of the frequency, phosphenes, flickering lights, like looking through heat of waves or water, visual snow, white spots, being formed like a crescent or chi-shaped. Then we have also hemianopsia, deformed image, tunnel vision, curved or circular lines, colored dots or spot of light, black spots, oscillopsia, that is a sense of motion of stationary object, fractured vision, anopia, that is total blindness, and alteration of the perception of distance. Then, also recently, I performed a systematic review of where we search for all the visual disturbances described in migraine aura in systematic clinical studies in the literature. Of course, we find other ones, less frequent disturbances, like corona phenomena, that is an extra edge around the object, like a negative film, slanted vision, complex hallucination, kaleidoscopic vision, and achromatopsia. So in the same review, we put all these disturbances in a table. These disturbances are 25. Also, we add some other feature that should be added when you describe some visual disturbances, like color, the internal pattern, if the figure is it can be like big, not a single line, for example, and the scintillation flickering. And the scintillation is, of course, a fluctuation of intensity, and I not agree with the classification that use the word scintillation for indicating a positive phenomenon, because scintillation it means a fluctuation of intensity. As I told you before, the elementary visual symptoms can be one in 1 hour, but can be also more than one in 1 hour. In my studies, the median were 2, with a range from 1 to 4. And here is an example of a part of a big table with all the auras of my patient, and you can see there can be many different elementary visual symptoms in same auras. The colors. In a studies from a Brazilian colleague, Queiroz, that did a lot of studies about aura, you can see that from 20 to 40% of auras of the patient, that could be also some colors in auras. This in the classification is not reported, unfortunately. Sensory disturbances. Say in the criteria C, it reported that the symptoms should be positive. It is explained like pins and needles. In the comments, it's reported that numbness may occur in its wake, but numbness may also be the only symptoms. And this is supported also by my study, where most of disturbances are positive, 90%. There is paresthesias, but in some cases, in 10%, just negative symptoms. And for these phasic disturbances that are less frequent, about 10% of disturbances that are usually aphasic, for what classification explain, but often hard to categorize, and this is actually is correct. Also the clinical studies are lacking of specific tests about this aspect. So let's go to the criteria C. And the first one is that at least one symptom spread gradually, okay, which is a very important feature. Here in the literature, we found that from 2% to 23% of cases, there is no gradually spreading of symptoms, but the problem here is that most of the studies are retrospective. So here is a big recall bias. Unfortunately, in my studies, I didn't include this specific aspect. And also there is no any definition of what they mean for gradually progressive. So this is a lack of the clinical studies that should be ameliorated in the future, okay? But for other aspects, a lot has been done. We will see. The other criteria is 2 or more aura symptoms occur in succession. That means one after the other one. And I performed specifically one study for the temporal aspects in migraine aura. And here you can see in yellow all the auras with 2 symptoms. I studied either the aura with 2 and 3 symptoms. In yellow, the symptom A, and in black, the symptoms B. And there are 4 scenarios. They can start together, or the second during the first one, the second at the end of the first one, and the second after a free interval of time. And either from, as I told you, aura with 2 symptoms or 3 symptoms, and they can start together in 34% of cases or in 18% of cases. So it's not uncommon that 2 aura symptoms can start together. So as I told you at the very beginning, for example, in this case, this criteria in 1/3, 20, 30% of cases is not true, for example. So just to keep in mind. Yeah. Another thing, this is very important. This is very important for clinical practice, for everyday clinical practice. Each individual aura symptoms lasts from 5 to 60 minutes. And this is not just present in this criteria. This is also present in the description of the typical migraine with aura, okay? Because they say duration of each symptom is no longer than 1 hour, okay? So this is more than one criteria seen. And I specifically investigated this aspect because my patient need to write the exact time of the beginning of one symptom at the end, the time of the watch. So it was something reliable 100%, no recall bias of each symptoms. So as you can see, the line of 60 minutes, the median time is 20 to 30 minutes. Yes, most of patients has an aura that is 50, 20, 30 minutes, but it's not uncommon that overcome the 1 hour. So you can see the visual 11% to 25% of sensory disturbances. And this is for 297 aura disturbances. And I put all these disturbances together, almost 300 aura disturbances, and everything more than 1 hour is 15%. That is quite a lot. And I ask myself, where is the 5% tail, which is what we normally consider atypical? Here, more than 4 hours. We can discuss if this could be the cutoff to move here or to move to 2 hours, but here is the 5% tail. Okay, and this is very important for the clinical practice because I see a lot of colleagues that for patients that when aura overcome is more than 1 hour, they are in dangerous, put the patient in the CT scan, thrombophilic exam. No, this can happen. This is not uncommon. Okay, it depends then when it stops, of course. Also, I perform a specific study to investigate if auras, including symptoms more than 1 hour, are different from the others auras for all the possible characteristics investigable, and there are no differences. Okay, we wrote a specific paper for that, and they are phenotypically similar to non-prolonged auras. So, another thing, at least 1 aura symptom is unilateral, okay? This is another important thing because either from my studies and from the study of Kairos, from in a range from 40 to 50% of cases, this is for visual aura disturbances, patient has bilateral disturbances, or in all the auras, or sometimes in 1 hour and sometimes not. But you also can witness from your daily practice, a lot of patients are sure that the symptoms are bilateral or during all the aura or in some part of the aura. And this is true also for sensory symptoms, not that much, but it's incredible the overlap with other studies. In my studies, the sensory symptoms were bilateral in 15%, and in the literature, 2 very important studies from Russell Erickson, the Danish group, was 14 and 16%. The overlap was incredible when I searched in the literature, okay? And an interesting thing that when I presented this data in London, at the migraine task, at the end, one person said, okay, but this could be anxiety. And I told him, okay, these are prospective data recorded with diary. First of all, I am a clinician and I need to collect data. I leave this speculation to other things. But remember that even area unilateral in the brain can produce bilateral symptoms. Another thing is that, another sub-criteria is that at least 1 aura symptom is positive. These are unpublished data. I performed this analysis just for this Congress, but I pulled this data from the studies of 2011. And and I realized that 21% of aura did not include any positive visual or sensory symptoms. So this also is quite common aspect, okay? So just a negative visual and or sensory symptoms can happen. The last one, the aura is accompanied or followed within 60 minutes by headache. As I told you, I did this study specific for temporal stuff. And in yellow you have aura. In black you have the headache, where can all the scenario of headache where can start. And in the bottom is the situation when headache start after a free interval of time. And yes, this is totally true. In 99% headache start within 60 minutes. Okay, the median interval of time is 25 minutes. And just let me to remind you that headache can also start before aura. In 10% of cases. Before, in the previous edition of the classification, this was not included, and now in the comments is reported, which is true. So, for concluding, international classification of headache disorder is very important for diagnosing migraine aura, and the criteria are very good for doing that. But it's not all the story. This criteria, the classification should be ameliorated maybe in the comments with a list. I suggest to put at least a list of all the visual disturbances, okay? But we also need more clinical studies, and I suggest also the dissemination of the knowledge, okay? Because at least I think the classification is good. Clinical studies are good, but also we need to spread information on what is aura, and this should be done. I would like to close with also some images of the winners of a contest of aura painting that some Brazilian colleagues has done, because also some colleagues also with aura can also. Some art can be done, and these are the digital art part. And thank you for your kind attention.